We started with Alzheimer's. We have seen what are the conditions in Alzheimer's. Some of you are responding with the whatsoever assignments I am giving, but I did not receive any reply on the one interesting assignment which I gave. Go through the or see the watch the black movie and check it out. You can see various signs symptoms of Alzheimer's. I did not receive anything about it, that whether they watch, what they concluded, how they can see about various sign symptoms, how they can judge the first sign and the progression of disease, because it indicates almost progression of disease from the first incidence to the subsequent deterioration. So this is how this Alzheimer is, and once the neurons they are getting damaged, then it is very difficult. We can just stop the progression, we can just minimize the rate of progression, and we can just prevent the very rapid degeneration, but we cannot bring back whatsoever lost has been there, whatsoever loss is there, that cannot come back. And there are many theories are there, we have seen about it. There are tau proteins are there, then neurofibrillary triangles are there, presence of some filaments are there, and we have seen that how in whatsoever autopsies are there, the dead persons shows, and even the CT scans. CT scan is one of the very important diagnostic tool that indicate, that gives idea about the presence of some kind of changes, like then some plaques are there. Okay, so there are variety of things are there which are very typically found in Alzheimer's. Apart from Alzheimer's, there are other dementia also, as I told you. Senile dementia means with age some of the neurons are getting damaged, but they are not Alzheimer. Why they are not Alzheimer? Because in that this very typical characteristics of Alzheimer, that is presence of tau protein, presence of plaque, presence of this neurofibrillary tangles, these things are not there. But there is a gradual loss of memory in that also. Senile means we know senior means aged one. Okay, so senile means with age. At the higher age there is dementia. What is difference in Alzheimer's? Because Alzheimer is having a very specific typical characteristics of presence of these various proteins and this neurofibrillary tangles, etc., and it causes very rapid degeneration as compared to senile dementia. Basic characteristics are same, basic things are, that is memory loss are there. One more assignment actually I gave, but I could not see any reply on that. That was what is memory, what is short term memory, what is long term memory, how memory is processed in brain. I asked this question also, but I could not see any kind of assignment on that. I don't know why. Maybe most probably I have made too many this applaud for you people, that yes, you are responding well. When you started with the sleep related activities, I was very happy, but I don't know, gradually it lost. Anyway, I hope there is no dementia in that, forgetting about what kind of assignments are given and what you have to do. Anyway, these are various ways, these are various reasons why they are there. So there are many pathology reasons are there. Apart from that, this presence of this tau protein and amyloid protein deposition, then amyloid plaque formation we call it as and neurofibrillary tangles, etc., etc. So there are many things are there. It has been found that high cholesterol has more chances, lipidemia is having more chances of having Alzheimer's, most probably because of conversion into this kind of fats which is there, including apolipoprotein and their analogs, they are formed and they are transporting cholesterol into brain, and then from that this all plaque, that is amyloid proteins and everything are somewhere formed. So they are found that, and therefore in certain cases statin like drug, we shall see it later, they can be helping, although they are not the primary treatment, but they can be supporting one. Now we have various diagnostic tools for that, and let us see these various diagnostic tools. We know very popular one is uh, for all kind of psychiatric activity and any psychiatric dysfunction. Anybody, which is the most widely used and the reputed scale, very popularly. Yes. Can anybody? We have seen all these scales. Can anybody try, which are very widely used and most recognized scale? We have seen it in depression, we have seen it in schizophrenia, we have seen it in bipolar diseases. Okay. No. Hamilton is comparatively specific for depression, but which is very broad one. We took whole one class for it almost. Yes, DSM, very good. DSM what? DSM 4, DSM 5. What is DSM? Very good. What is DSM? Depression, schizophrenia, mental something. Okay. Very good. Good. Very good. Okay. So these are various scale, and there are many other scales also. They actually measure various aspects of Alzheimer's. We have seen various aspects of Alzheimer in our introductory class. But what are various aspects? Apart from that, there are problems of cognition. Because of cognition, the person gets irritable. There can be chances of depression, and there are mixed type of these activities are there, which should be measured so that one can take care of it. There are various other scales also. One more scale is there, that is called as a mini mental status examination, that is MMSE, mini mental status examination. So that is MMSE is there. That score gives mild, moderate and severe one. That is, when MMSE score is around 18 to 26, then we call it as a mild. When it is 17 to 10, or that is 10 to 17, then we will call it as a moderate, and if it is less than 9, we will call it as a severe one. So how again, what will be clinical activities here? Here when it is mild, then patient has difficulty remembering some event, recent event. Again, you can take this assignment. You compare this with again black movie, because you will find it interesting. Compare with mild, moderate and severe scores with all these conditions whatsoever there. difficulty in remembering recent events, ability to manage finance, prepare food, carry out other household activities, then may get lost while driving, begins to withdraw from difficult tasks and to give up the hobbies, may deny memory problems. They may not accept that there is a weak memory or they are missing out something. Moderate means here patient requires assistance for activities of daily living. Frequently they become disoriented with time, like date, year, seasons. They may not able to remember what date, what kind of period is going on, like that. They can recall for the recent event is severely impaired. They cannot recall the recent event, and they may forget some details of the past life. Names of the family and friend they can forget. Functioning may fluctuate from day to day. Someday they may remember, someday they may forget, like that. Patient generally denies problem, may become suspicious or fearful. It loses ability to drive safely. Agitation, paranoia and delusions are common. Now this agitation, paranoia, delusions, these are the sign symptoms now what you have seen in psychiatric diseases. So now psychiatric component starts off. Then here last in conditions, the patient loses ability to speak, loses ability to walk properly, feed self, incontinent of urine and feces. They lose the control over that, and it requires 24-hour care. Means almost every time the care is required. So this is how Alzheimer's go into these are how the stages are, and during that the person may have variety of problems, because if they cannot do the things properly, then definitely there can be desperations, there can be irritations, and these are again additional behavioral aspects which has to be taken care of. So what are the clinical presentation? We have seen memory related problem is there, forgetting we have seen already. So apart from that, what it is there, various losses are there. That is, if you will see this various term, that is patient may have vague memory complaints initially, means they will not realize that it is there, but slowly they will find that the nearby people will notice it. Behavioral disturbances may also present in moderate stages. I told you, because of the irritation, desperations and sort of depressive mode it will be there. Loss of daily function will be common, and then definitely caretaker is required. So these are various sign symptoms like cognitive or memory loss, aphasia, eating problem, apraxia, agnosia, that is gnostic we call it as, that is cognition related problem. Disorientations are there, impaired perception of time and unable to recognize the familiar people. Impaired executive function, if you have to act on certain activities, suppose I ask you some question and if you cannot make a proper answer of it, that is impaired executive function. Non-cognitives like depression, psychotic symptoms like hallucination, delusions are there. Behavioral disturbances like physical and verbal aggression, motor hyperactivity, uncooperativeness, wandering. Again, these all signs I wish you try to correlate with the black movie. Repetitive managerialism and activities and combativeness, they become slightly aggressive in what case? Because they again psychologically they try to react with the situation in that way. Inability to care for self, they cannot dress, they cannot bath, they cannot go for toilet and eating. Gradually, initially they can definitely do it. If we see in mild condition, even they can drive, but they may forget where they have to go. But they may able to drive, they may able to manage the balance of that vehicle, or put it like that, but the problem will be there, and gradually it will be there. Now laboratory tests are there, whether some of these amnesias are there. When it is mild, we do not call it as a dementia, we call it as amnesia. Okay, amnesia is just, sometime it happens that that particular thing you cannot recall, although you know it very well, but that only that particular point of time you cannot recall it. That is amnesia. But when it happens again and again, then we can call it as a dementia. So check out whether there is a vitamin B12 deficiency or folic acid deficiency. Check whether hypothyroidism is there, thyroid function is not affected, blood count, electrolyte, liver functions, because all these can affect brain function also. And then go for CT scan or MRI scan. We have seen all these various scans earlier. And then all these scales, as I told you, there are many scales are there. DSM is one. Then there are scales available from AHRQ guidelines. Then American Academy of Neurology guidelines are there. And then NIN, that is National Institute of Neurological Disorder and Stroke, they have their own criterias. Then National Institute of Neurological Communicative Disorder and Stroke, that is NINCDS, and the Alzheimer's Disease and Related Disorder Association, that ADRDA, is having their own criterias. So these are various criterias are available, and on the basis on this scale one can go for. So this, as I told you, amnesia and this dementia has to be characterized, they has to be found, and all the cognitive activity, cognitive aspects are checked. So once we go through that, once these all are checked, then one can understand, and accordingly we can start the treatment. When there is a mild cognitive impairment, then we can have that when we take MRI and CT scan, we can try, we can identify it. And if it is a mild cognitive impairment, then we can just start whatsoever prophylactic therapy is there. This prophylactic therapy will help to avoid the progression, or to minimize the progressing rather. So this once we diagnose it early, then the progression will be slowed down, and thus we can prolong the better period, and person will not go into it. So what is our basic treatment? What is the goal we are having? Goal is because we can see the very difficult life they do have, because at the advanced stages, when we say that severe stage is that they cannot control their urination, they cannot control their feces, they do not understand the hunger, they do not understand the satiety, means they don't have rather any kind of senses we can have, but they are walking, maybe not properly, but still they can walk, they can have, some of them may be bedridden, but in all conditions they forget everything. So this is really a very difficult task, and for carer it is very difficult. Even carers get agitated with that, even they get problems. Our goals are what? To reduce this what we can say progression of the disease. We try to, because reversal is almost difficult, we cannot reverse. So we say that, see, if we see that what happens, no treatment prolongs the life of the person, means whatsoever Alzheimer people are untreated or untreated, they may have almost same life. Then what is the advantage of treatment? Only thing is they can just reduce the rate of progression, and because of that they give this quality of life world I told you earlier also. So they improve the quality of life of people both ways, of the patient also and the carer also, because it is not easy for carer. You can imagine the person is there and lost the memory, and it is just there in the family member itself is in family like he doesn't know anybody, and no control over that. It is easy to take care of the younger ones, the children who cannot control, but it is not easy to take care of such higher age people in that. So there are various resources are available for Alzheimer's diseases, and caregivers, the trainings has to be given for that. And there are many non-pharmacological treatments are available where you can give good food so that you can avoid it, you can have some cognitive behavioral therapies for various behavioral symptoms. Then you can try to take some care about sleep disturbances, wandering here and there, urinary incontinence, agitation and aggression, and they can be done with the CBT, that is cognitive behavioral therapy. So these are various non-pharmacological treatment one can take care about, and various other activities are there so that we can monitor for pain, hunger, thirst, constipation, and then full bladder, that is before micturition, and we can give some such indications. So these are all non-pharmacological treatments, so that we can guide, we can help the persons for that. So what are the various things we have to think about these people? Check, one has to check whether there is any vision, hearing or other sensory impairments are there, because again they may not able to express it, they may not able to tell it in proper way because they do not understand anything, they have lost this cognitive function. Cognition is even understanding what I understand. Okay, I don't know how many of you are understanding this, but cognition includes that also. That what I understand is cognition, what I do not understand, which is there, something is there but I do not understand, I have to do something in that. That is also sort of cognition. So here if they are not having a clear vision, then they can just, it can be checked by the carers or the relatives. For optimal level of autonomy and adjust expectation of patient performance over time, we have to see that how patient can do autonomously, means without any help, how we can help it. The confrontation should be avoided because we have seen that they becomes very agitative or what we can say more excited like. So the carer should, or they should remain calm, firm and supportive even if the patient becomes upset. Consistent and structured environment should be there so that they find it easy. Frequent reminders should be given, explanation, orientation, cues, some guidance, demonstration, some reinforcement. Reinforcement means memory reinforcement here, that so that they can remind the thing, they can remember the things way. Reduce the choices, because more choices, more confusion. I told about noise earlier. Here in Alzheimer's and all, the noises are there and they cannot process these noises. So this noises processing is very important. So reduce it, avoid complex tasks which can lead to their frustrations, bring sudden decline in the function and emergence of new symptoms to professional attendance. So these are various principles are there for caring this. Now let us see what are the treatment options for that. There are actually very limited treatment option. I ask you about the memory and how the memory is there. In that you could have found one answer that there are certain neurons which are participating. They are actually the just like computer. What is the memory of computer? In what portion? One may say hard disk. Then again next question is, suppose similarly we have got brain. Then how this memory is processed, where it is put into hard disk, in what form it is put into computer hard disk or RAM. Those who know something about computer, there are two important things which are real for computer or even your mobile phone. That is we called as a RAM, that is RAM is random access memory, which is immediate memory. That helps you to bring that path to relate to that portion particularly. If you need something, then that RAM will take you to that portion of hard disk easily, and or it will be this RAM will be important for the processing that function, and hard disk where that particular information is stored. In similar way, somewhere we have got our memory structure, and neurons are playing role into it. So usually our treatment is the therapy of cholinesterase inhibitors are given. We know cholinesterase inhibitors, and I told you earlier that those whatsoever drug we are using in CNS, basically they should be able to pharmacokinetically cross blood-brain barrier, because until and unless they cross blood-brain barrier, they cannot act in CNS. So these are the drugs which are cholinesterase inhibitor, but they can cross blood-brain barrier. Their concentration in brain will be comparatively high. Drugs are donepezil, rivastigmine, galantamine. They are cholinesterase inhibitor, a different type of cholinesterase inhibitor actually. I am very sure you might have studied this in pharmacology. And another drug is there which is acting on NMDA receptor or glutamate receptor, that is memantine. So basically these 4 drugs are there, and there are other drugs are there which are used as a supportive drugs. So on that basis it is used. On moderate to severe conditions we use anti-glutamic therapy, that is memantine, and for mild to moderate condition we can select any of these 3: donepezil, rivastigmine or galantamine. Rather donepezil is newer one, it is comparatively more preferred, and rather we can say this is a sequence of donepezil, rivastigmine and galantamine. Then we have to titrate the recommended doses which are there, and check the behavioral symptoms, and if we need we can give any treatment for behavior if we see the more signs, or if our scales like DSM we have applied or any other scale we have applied, then if it shows the component like depression or bipolar or agitation, or that is more excitation, delirium type of conditions, then we can accordingly use various drugs, various behavioral therapies, and accordingly that approaches we can apply. So these are various drugs which are used. Again, which should be used first? There are different versions. People say that what should be used, but this basically 2 important things are there. For moderate to severe we use memantine, and for mild to severe we use these 3 agents which are these anticholinesterase inhibitors. So these are there. And one more important thing, whenever we have any drugs related to brain, that is many things we do not understand. We have to just logically conclude that, because here we can have example, what is a great difference between other tissues. Example, if there is any drug which is acting on any kind of smooth muscle or skeletal muscle, immediately you might have seen it during practicals. That is what happens during that is you can see the muscle contraction, or if it is a blood pressure increase or decrease in the blood pressure, and you can then conclude that yes, there is a vasoconstriction or something like that. Here we do not understand, because we have to go for logical conclusion, where they act, what action, which kind of indirect action they cause, because again we have got a very big complex of neuron, and these neurons are having again interlinked with each other. So drug is reaching to one point, showing action at other point, everything is possible in brain. So it is very difficult to exactly understand the basics. So these all are done on the basis of series of experiments and conclusion, and putting together one by one. Just like in childhood, you people might have put various what we call it as puzzles are there. So in puzzles, the various pictures are there which are having different cuttings, and you put this cutting one after another, and then you make complete picture. So here it is something like that, that various research are there, they are put together, and then the efforts are there to link it that this may be the reason. So these are various agents which are there. One more was there, that is tacrine. As I told you, it was sort of organophosphorus, and it was irreversible, but it causes adverse effect like hepatotoxicity, and therefore it is not used. And these all other newer are there, safer, like donepezil, rivastigmine, galantamine, and they show similar efficacy and almost similar adverse event to each other. They are well tolerated. Already you might have studied all their ADRs and activities. All activities, most of the adverse effect will be related to their increase in the acetylcholine concentration. So these are the drugs and their mechanism of actions. As you might have studied, will not go into this. And there are other drugs are there. Memantine, I told you, anti-glutaminergic, or it is acting on NMDA receptor. And this glutamate is a neurotransmitter which is acting on NMDA receptor, and it is antagonist for that. And it is found to be useful in the moderate to severe as a monotherapy, or sometimes it can be used in combination with donepezil, particularly when it is too high, the problem is too high. It will increase the efficacy where the cases are very moderate to severe, and they can do some of the activities in that cases. Other things are dietary supplements. They are not proven well, but people feel that we have seen that it is because of the oxidative stress. So people are tried with, they are trying with antioxidants. They are trying with many treatments. Example, estrogen. It has been found for the treatment or prevention of Alzheimer's. But some of the people say that estrogen shows a decrease in the Alzheimer's, because it was taken that uh, in female comparatively Alzheimer's chances are lesser. So therefore most probably people feel that either estrogen, progesterone may be participating into it, and they were tried, but we do not have very conclusive evidence that it is really working. Then various anti-inflammatory agents, we have seen that there are inflammatory tangles are there, if we can use some anti-inflammatory agent. But again, we don't have very clear confident data. Lipid lowering agent, I told you that the chances of Alzheimer's are more with various lipid, that is hypercholesteremia. And if we can reduce cholesterol using statin like drug, we can reduce. This was again one of the belief, and it can it will prevent, but maybe it will just support, or it will just help to reduce the progression. These are various agents which are there. There are many nutraceuticals, supplements, and medical foods are there. People have advice for. Again, we may not have very big data available for it. There are many people, they are working, they are trying to make a research of it, and they want to prove that how it can be there. The basic concept in almost all receptors are that in almost all such cases are, we call it as a nutraceutical or medicinal food products like that. That this food will have higher such agents that they will cause decrease in the oxidative stress, and because of this decrease in the oxidative stress, this will be helping, this will be supporting these people. So these are what various treatments which are having in the treatment of that. There are many few treatments are actually been coming, and in that again supportive treatment we can have if we have got another cognitive activities. We can give some antipsychotics like haloperidol, onarizepam, quetiapine, risperidone, ziprasidone, depending on the additional symptoms with that. If psychosis, hallucination, delusion, suspiciousness, disruptive behavior, agitation, this type of aggression, if these symptoms are there, then we can give antipsychotic. If the person is showing signs of depression, I told you about this, we are measuring this with various scale including DSM scale, etc. And then we can give antidepressive like citalopram, escitalopram, fluoxetine, paroxetine, sertraline, venlafaxine, trazodone. All these agents, any of these agents can be given accordingly. Anticonvulsants like carbamazepine, valproic acid can be given if the person is having more aggression or agitation. So these are various such non-cognitive symptoms, or we can say behavioral symptoms or psychiatric symptoms which are there along with dementia. And then these are also important. This has to be done. This is to be helping the people to avoid all this problem. So I think it is clear. I hope you have understood all this. You just let me know what next topic you can go for, because already we have gone through these details. Most probably, I think only stroke is remaining now. Parkinsonism we have finished. Then Alzheimer's we have finished. We can go for stroke. Okay. If you have any difficulties, you just let me know. what are the difficulties, so that we can try to solve. Okay, I hope everything is clear. Take care. Be safe.
सर
Yes.
सर हे हायब्रिड मोड जे दिलंय ते रिओपनिंगच्या फॉर्म मध्ये सर ते काय आहे नेमकं?
कसला फॉर्म मध्ये बेटा? हॅलो.
तर रिओपनिंगचा ते फॉर्म पाठवलाय ना, त्याच्यात मग ऑफलाईन मोड, ऑनलाईन मोड आणि हायब्रिड मोड. तर हा हायब्रिड मोड नेमका काय आहे?
हायब्रिड म्हणजे दोघं, ऑनलाईन प्लस ऑफलाईन दोघांचं कॉम्बिनेशन.
म्हणजे काही लेक्चर्स ऑनलाईन
हा,
होतील, काही
काही
लेक्चर्स
काही
ऑफलाईन
काही
होतील.
ऑफलाईन होतील, असं. तर
अच्छा, मग सर प्रॅक्टिकल नाही
असे
होणार का?
असे असे जे विद्यार्थी असतील समजा, की जे कुठल्याही परिस्थितीत ते येऊच शकत नाही, मग ते ऑनलाईन प्रिफर करतील. काहींना असं
हम्म.
शक्य आहे की कंटिन्यूस येणं शक्य नाही, पण कधी कधी तर निश्चित येऊ शकतील, मग ते हायब्रिड करतील. काहींना असं वाटतं असेल की नाही नाही आम्ही ऑफलाईनला, मी ॲक्च्युली फॉर्म तो मी बघितला नाही आहे. फॉर्म कारण महाप्रवेश सरांनी बनवून तो पाठवला होता आणि त्यांनी सरांकडनं गायडन्स घेऊन त्या पद्धतीने पाठवला आहे. तर आय एम नॉट एक्झॅक्टली शुअर, पण त्याचं मिनिंग तुला सांगू शकतो मी. मिनिंग असं आहे की ऑनलाईन हे ऑनलाईन आहे, ऑफलाईन म्हणजे कॉलेजमध्ये येऊन करायचं आहे, आणि हायब्रिड म्हणजे त्याचं कॉम्बिनेशन आहे, ऑफलाईनचं नाही, याचं ऑनलाईनचं.
अच्छा. ओके सर. ओके.
प्रॅक्टिकलचं काय होईल? प्रॅक्टिकलचं पण समजा जे लोक ऑफलाईनला येतील त्यापैकी काही लोकांचे जेव्हा प्रॅक्टिकल होतील, तर असं एक एक्सपेक्टेड आहे की त्यांनी ते प्रॅक्टिकलचं व्हिडिओज वगैरे शूट करून घ्यायचे, ते तुम्हाला शेअर करायचे बाकीच्यांना, जे लोक येऊ शकत नाही त्यांना. आणि
अच्छा.
ती जशी जशी पुढे थोडंसं जाऊ तेव्हा थोडंसं मॉडॅलिटी आम्हालाही क्लिअर होईल. कारण आम्हाला जेव्हा 50% सांगितलं आहे, आम्हाला स्वतःला अडचण अशी आता सगळं प्लॅन करताना, की तुमच्यातले नेमकं किती यायची इच्छा करतात, किती येऊ शकतात, पहिली गोष्ट ती. त्याची मग सगळेजण यायचं म्हणत असेल तर मग 50% करावे लागतील. ऑलरेडी 50% असेल तर मग त्या पद्धतीने 50% करायचं कसं, हा सगळा एक भाग आहे. तर एखादा आठवडा आम्हाला पण त्या ऑब्झर्वेशनमध्ये आणि कन्क्लुजनमध्ये जाईल. तर आता तुमचा डेटा मिळाल्यानंतर आम्हाला त्याच्यावर तसं वर्क करावं लागेल.
ठीक आहे सर.
इट्स
ओके.
क्लिअर ना? होप. एनिबडी हॅज एनी अदर डिफिकल्टी? काही अडचणी आहेत कोणाला अजून? दुसऱ्या काही अडचणी कोणाला?
हॅलो सर.
हां, बोल.